Okay, this is Alzheimer's disease, dementia, and delirium. And I know I quickly covered it in class, but of course that was a very Cliff Notes version. So I'm going to do a full lecture here for you. Uh, Alzheimer's disease is a chronic disease, it's progressive, and it's degenerative. It is the most common form of dementia. Over 50% of all cases of dementia are Alzheimer's. It is also a sixth leading cause of death in the United States. So it it is a big deal. It's one of the most expensive diseases we have in the United States. We really don't know what causes it. There is a genetic part of it. There aging definitely is a risk factor. That does not mean it's a normal part of aging. It just means that as you age, you are at higher risk to get Alzheimer's disease. We think it has a link with inflammation, with viruses, with diabetes, smoking, depression. There's just all sorts of links we think are there. Now, the genetics, just so you know, the reason it says sometimes is because I don't want you to think we should immediately test everybody genetically. It's really early onset AD. So if it starts before age 65, we should check the family history, and it's more likely to be a more rapid progressive course. The patho of it all, sorry, the pictures are missing on this audio, but they're on your regular PowerPoint. And it doesn't really matter, to be honest. We have plaques, we have tangles, and the truth is all of those are in everybody's body in normal brains, but they're more plentiful in AD. And the only way we can really see them is at autopsy. We can see some changes in the brain, like brain atrophy, but those are late stages. It could be due to other things, so there's really not a way for us to diagnose this. So the symptoms of AD are mostly characterized by loss of memory and then judgment problems, and then a change in their personality. So over time, they're going to get much worse and become really impaired cognitively, and then ultimately have physical deterioration where they need total care. I put this up here for you to think about. This is a table in your book, and just look at the normal forgetfulness, because we all do those things, compared to mild problems, compared to Alzheimer's disease, where they have significant problems. And it's what we talked about in class, that they not only they not remember somebody's name, they don't even remember they know them. They don't just lose their keys, they put their keys in the refrigerator or in the bathroom closet instead of putting them somewhere that makes sense. So it's a bigger deal than just normal forgetfulness, and you do need to recognize the difference between those. Here are the other symptoms, and I talked about the cognitive changes. That deterioration in their memory is the first sign, and then that will get worse and worse and eventually end up with long-term memory loss. Their behavior and personality changes. They won't take care of themselves physically. They oftentimes get very agitated, very aggressive. Sometimes they're really funny at first, like they're childlike and funny. And then most, though, at least at some point, end up being very aggressive. And that's usually where they end up needing some full-time care, either daytime care or moving to a facility, because the family just can't handle them because they're dangerous to them. They do end up with confusion at night. We call that sundowning, and then ultimately will end up unable to care for themselves at all. Now, these are showing symptoms of early dementia, moderate dementia, and then severe dementia. So you can just kind of see the progression of that. So, look through those and kind of make sure you can understand the categories. So we really don't know any way to prevent Alzheimer's, although there's all sorts of things out there, eat omega-3s and limit inflammation, and now there's a bunch of stuff about controlling your blood sugar, and all of those things may be helpful, but since we don't totally understand it, we aren't sure of that. So it's not going to hurt anybody, but it may or may not work. And what's more important is that we recognize the disease early, because there are some treatments that can be done that are helpful to slow the progression. So recognizing it and getting it diagnosed, or at least other things excluded. So a lot of research being done on diet changes and exercise and NSAIDs and how those things may or may not help. Again, there is no test. It's a autopsy that will confirm it. But what they will do is exclude other things. So to do a CAT scan, a PET scan, an MRI to make sure that they don't find a tumor or some other neurovascular change. They'll do labs to make sure they're not mimicking the signs. So thyroid changes or liver changes, things that we could treat. And then neuropsychologic testing. By the way, brain atrophy, yes, is a symptom, but it is not a diagnostic thing because brain atrophy can occur with other disorders. Treatment, again, there's no cure. There is really no true treatment, but there's things that will kind of slow things down and help deal with some of the symptoms. So our goal is to improve their cognition and control those behaviors that are not appropriate. So cholinesterase inhibitors, you probably recognize the names, Aricept, Exelon. The earlier we give these, the better. So as soon as they recognize it. Namenda works differently, so it's another drug they can try. The antidepressants can sometimes help improve their cognition, but they also really help them with sleep, which is a big problem for them. So it does double duty. Antipsychotics are used for agitation and the aggression, but there are studies out there that show when we use antipsychotics in dementia patients that it does cause a risk of death, so we just have to be very careful with them. Now for nursing care, and this is primarily what I test you on, some on symptoms, but mostly on the care, the big thing is giving them structure and consistency. They need routines, and if they have routines, they feel better, they're less likely to get agitated. So there's reminders in those facilities, Alzheimer's units, really, they know that they wake up, they put on their robe, they go to breakfast. And then when breakfast is done, they go back, they get dressed, they wash their face, and then it's maybe activity time, and then it's lunch. And they get a security in that. Also, we don't want to stimulate them a lot. Things like, making sure that we don't just leave a TV on for noise. They're better off if they don't have that. And, making sure at night that they can sleep undisturbed for a period of time. Things just not to overstimulate them too much. Not extreme, but just being conscious of that. Helping the agitation. First of all, remember that people can get agitated if they can't communicate well. So it may be that they're in pain, or maybe they need to go to the bathroom and they're having a hard time explaining that. So look for those signs of discomfort first, and then those are easily resolved and may fix the agitation. If that doesn't need to be done, or that's not the problem, then you've got to do things like redirect them, distract them, reassure them that they're fine and that you're here and that they're safe. So redirect, you can just give them a task to do. They like to be busy, so maybe you let them sweep something or clean something, or just give them something to do. Distraction, talk to them, listen to music, take them somewhere. Way better than confronting them, asking them, why are you doing this? They don't know why they're doing that. That doesn't do any good to ask them that. So other things, limit number the choices. Don't ask them 100 questions. Don't say, do you want to do this or this or this or this? Just pick something and offer it to them. Really simple, short directions. Again, you're trying to prevent agitation, not cause agitation. So threatening won't help. Confronting them, explaining, like, remember you're here, and don't you remember that it's this time and you're supposed to do this? They don't remember all that. So you can quickly mention it, but it's not going to do any good to try to convince them. So be really careful. Restraining them is going to make them more agitated. So it's really the redirect that's the best for them. We really don't want to give drugs. We can do that if we have to. If they're a danger to themselves or others, we can certainly do those antipsychotics, but those should be our last resort. Injury is a big potential for them. Falls, so your typical fall prevention things, but wandering. We often call that elopement. where they have gotten out of a facility and then they don't know where they are and they wander. You've seen those silver alerts. Oftentimes it's Alzheimer's patients that have wandered off and they don't know where they are and they just keep wandering because they're agitated. And the problem is the elements can get them. It can be too hot or too cold. And so oftentimes, if we don't find them quickly, we will find them dead. So, really important that we keep them from wandering. So, that's giving them supervision, whether they're at home or in a facility, that they have 24-hour supervision. Medical alert bracelets, so if they do wander off, somebody could look at that and see that they're an Alzheimer's patient, this is where they belong, and this is the phone number. Alarms on doors in Alzheimer's units, they have locked doors or doors that alarm when they're opened, or sometimes even bracelets that they wear, and when they get close to an exit, it goes off. You shouldn't ignore those alarms in those facilities because it may be a patient getting out. Room close to the desk. If it's not an Alzheimer's unit, of course, you can't put everybody next to the desk. But if it's not an Alzheimer's unit, then that'd be a good thing to do so you can watch them. They do like to pace. So oftentimes in Alzheimer's units, they'll have a special place. Like there's red tape on the floor. That's their boundary. And in between that, they can just walk to their little heart's content and pace back and forth. All right, disturbed sleep, particularly due to sundowners. Boy, I have admiration for those people that work in these units because every night when the sun goes down, everybody gets agitated and wandering. So the best way to handle this is to make sure they're tired at night. So keep them busy during the day. Don't let them nap during the day. Make sure they know it's day. So open the blinds, turn on the lights. Don't let them have a lot of caffeine late in the day. So things that would just encourage sleep. Also, you can look at their meds and make sure that they're not taking any meds that are going to cause sleep disturbances. And then a bedtime ritual. Again, they like that routine. So maybe, every night at 8:30, you get your pajamas on and maybe you watch Jeopardy and drink some milk, eat some cookies, and then it's time for bed. So just having a ritual is very helpful. So as this disease worsens, they will end up needing at least adult daycare just to give the family a break. And then oftentimes they do need to move to an institution because they're just very hard to manage. Nutrition becomes a problem as this disease progresses. Remember, they're going to get total immobility and need total care. So eventually they're going to get to where they have swallowing difficulties. So also they can't eat enough food for all of the movement they do at that pacing. So supplements. Infection is often what kills them. So, preventing UTIs, pneumonia, the things that the elderly are more prone to. And then once they have total care, dealing with that. Caregivers need a lot of support. Refer them to support groups and other people that are going through the same thing just to help them because they are very prone to depression. Not just the patient, the family is from dealing with that because now mom and dad or whoever it is, mom or dad, don't know them. They don't remember things. Watch the Notebook. You can just see how there's just times where she remembers, but other times she's not herself. So that's dementia. Well, that's Alzheimer's, which is a form of dementia. It's the most common form of dementia. It's not the only form. So now I want you to look at dementia versus delirium. And we do test on this too because the care is different and the prognosis is different. So you do need to understand the differences between them. So we've kind of talked about what dementia looks like. It looks like Alzheimer's. So let's talk about what delirium looks like. Delirium is an immediate rapid onset. So maybe you do have grandma who is sharp as a tack and she's fine, never had any problems. She goes to the ER because she's got some belly pain. They discover she needs surgery. After surgery, she wakes up, she's talking kooky talk. Or maybe she was fine and now she's talking kooky talk. That's not normal for her. So the most common cause of that is some other problem like a fluid electrolyte imbalance or hypoxia. So we got to rule those physiologic things out. But once we've ruled that out, This may just be her body's response to that stress of hospitalization. So what we see in comparison to dementia is grandma's talking kooky talk right now, but then the next time you come in, she's perfectly fine and interacting with you. She knows where she is. She knows what day it is. She's fine. The next time you come back, she doesn't know where she is, but she knows everything else. And then a couple hours later, she's fine again. So you have these periods of lucidity and then periods of strange behavior. And that will fluctuate in severity. Sometimes it's really bad, other times it's just mild. So there's really no point in testing their mental status like with the mini mental status exam, because when they're in this period of delirium, it's going to be off. But once they're back to normal, it would be back normal again. So very different from what we talked about with dementia, which is a slow onset, progressive. They never get better. They just continue to get worse. So with dementia, we need to look and make sure there's not a true cause that we can take care of. But recognize those symptoms are very, very different. So the really key distinct difference is a sudden change. They have a sudden change in their mental abilities and their behavior. That's usually delirium and not dementia. Now, you do need to understand the difference of caring for them and testing. So with dementia, we use the mini mental status exam, and I just put a reminder of some of the things we ask with that to continually monitor them. So we're going to look at that and kind of get a baseline, and then 6 months from now look and see how much they've deteriorated, and 6 months from now how much more have they deteriorated, and we're going to expect continuous deterioration. They will do CT or an MRI just to make sure there's not some vascular problem they can deal with, or something confusing the picture, a head bleed or a tumor or something. Other than that, your care is like for Alzheimer's disease. Now with delirium, it's recognizing who's at risk for that and then recognizing the symptoms, and we use the confusion assessment method. This checks, is it a fluctuating course? Do they have trouble focusing? Are they ever incoherent? Have they ever had a loss of consciousness? And then it looks at the comparison. So it really is those symptoms we've talked about. So only if we think there's an injury do we do a bunch of testing, other than looking for precipitating factors like a sodium level difference or hypoxia, that kind of stuff. So the treatment for them is to just reorient them, provide safety when they're having delirium episodes, and then reorient them, remind them where they are. Now, if they are elderly, make sure they have their glasses and their hearing aids and they're in. It may be that they're not really delirious, it's that they can't hear you or see you. So make sure they don't wear them and they need them. And typically we don't use drugs unless it's just a really bad episode. It will go away typically on its own eventually. So I'll let you look at these questions and look at the answers. Again, remember, I put these questions on there knowing that we don't love these questions. So this is a confusing question, but when you read the rationale, then you understand how we get there. And so it's really just there to help you with test-taking techniques. Here's another one that you can look at and on the PowerPoint and look at the rationale. And one more.